Hello, my name is Tuomas Rissanen. I'm an interventional cardiologist from Joensuu, Finland, and my topic in this online meeting is DCB for the treatment of novo Coronary Artery Lesions in patients with high bleeding risk. These are my conflict of interests. We have quite extensive experience on DCB only approach for de novo lesions. I think we were among the first ones in Europe in 2009 to start this new method, and at that time in our old cath lab we had a analog clock on the wall which only could show seconds to help us keep DCB balloons open for prolonged times. In the last year we did about 1000 PCIs in our center, and you can see here that over half of the PCIs were done using the DCB only approach. During the first decade that the method was in use in our cath lab, we have done over 2,500 PCIs for de novo lesions using DCB only approach. I would like to start this presentation with the case report. 79 years old man was admitted to our emergency department for severe dyspnea and anemia. There was a mild troponin elevation, no bleeding shock. Gastroscopy showed normal results, but colonoscopy demonstrated colon carcinoma that should be operated within the next few weeks. The patients received 3 units of transfusion. Coronary angiogram demonstrated a tight lesion in the right proximal LAD, and both anesthesiologists and surgeons were in a strong opinion for that the operation for colon carcinoma cannot be done without revascularization. So we had basically a few options, either to implant third generation DES using 1 month DAPT, or to send these patients to coronary artery bypass surgery, or then treat these patients perhaps with plain out balloon angioplasty. Or the fourth option would be that to treat these patients with the DCB only approach. The patient was given aspirin, a small amount of enoxaparin, but no ADP blocker, and predilatation of the LAD lesion was done with a non-compliant 3x20 balloon. After predilatation, there was a type B coronary artery dissection, but the patient didn't have any chest pain. There was no ECG changes, and there was T3 flow without any significant recoil in the target vessel. So we thought that this patient is suitable for DCB only PCI approach according to the current consensus group guidelines. Consequently, second place DCB was applied for 1 minute on this lesion, and here you can see the final result. The flow is normal, T3. There is still significant dissection without any flow disturbance, and the patient only received aspirin and thrombi prophylaxis for the next few weeks. The patient had successful surgery for colon carcinoma 2 weeks after PCI without complications. He demonstrated very poor compliance to medication, and he had stopped using aspirin luckily we didn't implant DES because of the risk of stent thrombosis. This is a control angiogram 4 months after the DCP-only PCI, showing enlargement of the target vessel and healing of the target area. The patient has been asymptomatic for coronary artery disease for 4 years after PCI. I think that the restenosis is not a significant problem anymore after PCI using modern DES, but bleedings are, especially in patients on anticoagulations, either on warfarin or NOACs. These data are from Pioneer AF study showing that the bleeding risk is from 15% to 25% in patients using warfarin after PCI. A recent meta-analysis having over 30,000 patients demonstrated that bleeding during the first year after PCI is an independent risk factor for death by the factor of 7. The reason is probably that bleedings lead to cessation of DAPT, and they also increase the risk of thrombosis and ischemia. So the prevention of bleeding should be a major goal after PCI. So why to use DCP instead of DES in patients having elevated bleeding risk? The short 1-month duration of DAPT is currently the same in DCP and DES protocols, but in selected patients, as I showed, only single antiplatelet therapy can be used after PCI using DCP only approach. And in case of bleeding, all antithrombotics can be stopped immediately after DCP PCI, which is not possible during the first 4 weeks after PCI using DES. And then, as I will show later on, there is a very low target lesion revascularization rate after DCP only angioplasty. There is a very low risk of acute vessel occlusion after DCP only approach, and it is less than using drug-eluting stents. And when DCP is used, we allow the positive remodeling of the treated vessel in the later few weeks and months. We have recently published papers on our DCP only approach for de novo lesions in our center. We included all patients that received DCP only approach for de novo lesions during the first 4 years that we used DCP. We had 600 patients, and we separated these data to patients having rotablation followed by DCP, and the rest of the patients treated conventionally without rotablation. We excluded the patients that had DCP for in-stent restenosis. In this all-comers registry paper, the MACE rate at 1 year was low, 7% in patients having stable coronary artery disease, and it was 12% after acute coronary syndromes. The ischemia-driven target lesion revascularization rate was also very low, 1.4 and 2.8% respectively. The median follow-up was 18 months, and the bailout stenting rate was 12. In this second arm of this registry data, we published the patients that received rotablation followed by a DCP only approach. We had 82 cases. And which is remarkable, 82% of these patients had at least one risk factor for bleeding. In this paper, we were able to demonstrate that DCP-only approach after rotablation is both safe and effective. The MACE rate was 14% and TL rate was as low as 1.5% 1 year after the PCI procedure. This was the first paper showing the efficacy of rotablation followed by DCP-only approach. This is a case example of rotablation followed by DCP-only approach. This is an old female having a tight, complex calcified circ lesion. Rotablation using 1.75 burr was done because we were not able to cross this lesion with a small balloon. After plateletation, a long drug-coated balloon was applied to this lesion. This is the acute final result after a DCP-only approach in this vessel. There is no dissection or significant recoil in the target area, but the flow is a little bit slow after rotablation. Importantly, this patient had a control angiogram 2 years after rota plus DCP-only approach, showing enlargement of the target vessel and a very good long-term result. After having the good results in the registry studies and also very good clinical experience on DCP-only approach in de novo lesions, we designed a randomized control trial in patients having elevated bleeding risk. And the results were published in the Lancet journal in 2019. The background for the DAPT trial was that the optimal PCI technique was not known a few years ago, and it's still unclear in patients with bleeding risk. Currently, DCP is approved for the treatment of ISR, both by the ESC and international guidelines, except for American guidelines, which do not recommend the use of DCP at all. But only little data exists for the use of DCP in de novo lesions, and there is only one published RCD with clinical endpoints before this DAPT trial, which is the basket small 2 trial. And the major advantage of the DCP-only strategy is that the DAP duration can be short and positive remodeling of the treated vessel may occur. And the hypothesis of the DAPT trial was that the DCP-only strategy is non-inferior to PCI with BMS in patients with bleeding risk. The reason for using BMS as a control was that in 2013 DES was not indicated in PCI in patients with bleeding risk by the ESC guidelines. The inclusion criteria can be seen here. We included both patients having stable angina and documented myocardial ischemia or ACS, and the patients had to have at least one de novo lesion in native coronary artery or bypass vein, and the reference vessel should be in range of 2.5 mm to 4.0 mm, and most importantly, the patients had to have at least one risk factor for bleeding. The major exclusion criteria were dissection, reducing blood flow or significant recoil after plateletation, instant restenosis, unprotected left main, chronic total occlusion, STEMI, too small or too large vessel, or bifurcation lesion requiring 2 stent strategy. The primary endpoint of the DAPT trial was MACE at 9 months, and the key secondary endpoints were TLR at 9 months and 3 years, as well as MACE at 3 years. According to the power calculation, we had to have 530 patients recruited, but the recruitment was prematurely terminated due to slow recruitment process after 208 patients, and the reason for this being that previously the experience on DCB in de novo lesions was scarce in Finland, and we had difficulties to recruit patients for this trial. We had 5 participating centers in Finland, and the patients were recruited in 4 years period of time. PCI was done according to the international consensus guidelines. Predilatation was done to the nominal size of the vessel, and after this 12 patients were excluded after predilatation due to flow limiting dissection or too much recoil of the target lesion. The patients were randomized either to second release DCB or bare metal stent. The mean diameter of the both devices were approximately 3 millimeters, demonstrating that this is the first randomized control trial addressing DCB-only approach in large native coronary vessels. Only 2% of the patients had bailout stenting after DCB-only approach, and the reason for this is probably that we randomized the trial, randomized the patients only after predilatation. And the DAPT duration was 1 month in both groups in stable patients and 6 months after ACS. The patients were quite old, about 76 to 77 years, and risk factors were quite traditional. The only difference between the groups was that there were more diabetics in the BMS group by chance. About 46% of the patients had ACS in randomization. These are the inclusion criteria for the DAPT trial. The anticoagulation was the most significant criteria for inclusion, followed by advanced age, anemia, prior intracranial hemorrhage or stroke. The most prominent target vessel was LAD. We had bifurcations in this trial, calcified lesions, and cutting balloon and rotational atherectomy was used in a minority of cases. These data show that complex lesions were included in this trial. These are the device data showing that large coronary artery vessels with de novo lesions were included in this trial, and about 60% of the target lesions were 3 millimeter or more in this trial. In the vast majority, only one device was used per lesion, and the mean diameter in the DCB group was almost 20 millimeter and BMS group about 16 millimeter. Primary result of the trial, which is the MACE at 9 months, and it shows that only one patient had MACE during the 9 months period in comparison to 15 patients in BMS group. This result was both non-inferior and superior for DCB against BMS, and which is very important, the result sustained during the 3 years follow-up with statistically significant difference between the groups. This is the secondary endpoint of the trial, which was TLR at 9 months. It showed that there was no case of TLR in DCB group in comparison to 6 cases in the BMS group. However, during the first 3 years, there was a sort of catch phenomenon in the DCP group, so that there was no statistically significant difference anymore at 3 years between the groups. What's very interesting was that there was a difference in total mortality between the groups, although this was not a pre-specified endpoint of the trial. However, it showed that total mortality was lower in the DCP group in comparison to PMS group, and this is very important in terms of safety of DCP therapy in patients having coronary artery disease. In terms of cardiovascular mortality, there was also a clear difference between the groups. I'd like to end this presentation by concluding that PCI using DCP-only approach is both safe and efficient for treating de novo lesions in patients, especially in patients having bleeding risk. The DAPT trial was the first randomized controlled trial addressing this issue, and it showed that PCI using DCP-only approach was more effective and safe than PCI using BMS, and these results persisted up to 3 years. The trial also showed better cardiovascular survival in patients having had PCI using DCP, and I think these results should change the current recommendations that we have for revascularizations of patients having bleeding risk factors. What we need in the future is an RCT comparing DCP-only approach against DES in patients with bleeding risk. I would like to thank you for watching this video, and I hope to see you in Korea next year's meeting. Bye bye.